Okay, our next speaker this morning is Dr. Lynn Roberts, and she's joining us from the Enterics section at the Wisconsin Division of Health Services. And she's really going to talk to us about the importance and what they really see from samples that they get for surveillance. So go ahead, Lynn.
Yes, good morning. I'm going to practice my mic technique. It's been a while. So I am going to talk. So I decided for folks, kind of IPs and lab folks and public health folks as well, that kind of going through one case kind of in depth would be a really good way to demonstrate just how important every isolate or every specimen can be. So hopefully you guys will see that. This is weird. I got to back up. Okay. So just to start, I'm going to go through this case in depth. Hopefully you all enjoy it. I know it's fun to pull out my clinical talking skills. Okay, so we have this one case. Woman's name is Jennifer. She's about 49 years old, Wisconsin resident. And so she had traveled to Florida and came back about 2 weeks ago. And 2 weeks after she got back, she was on the phone with her brother and complained of a really, really bad headache, which is fun. Brother could not reach her the following morning and was concerned, so came over to Jennifer's house, had a key, walked in, and she was unresponsive in bed, which is, I would imagine, quite frightening. So Jennifer's brother called EMS, and she was transported to a local emergency department. Okay, so as I mentioned, she was unresponsive. When EMS found her unresponsive, she had increased respiratory effort and was hypertensive. And once she was at the ER, ED, they intubated her, sedated her, of course, and then her blood pressure quickly improved. Okay, so right away their concern is that she had had a stroke. They did a head CT, though, and there was no evidence of that, thankfully. But they did see diffuse paranasal sinus disease, which I would like to see some of these CTs myself. Anyway, the only really history that they had when she had presented this ER was that about 8 days before, so 9 days before she presented to the ER, she complained of shortness of breath, flu-like symptoms. That had started right after she'd returned from Florida, and she'd been diagnosed with bronchitis and then given breathing treatment and I believe some steroids. So don't have any other medical history. The only thing that they know of is that she's morbidly obese. So we have nothing else to go on. Okay, so at this point, stroke is off the differentials list. But given everything else, there's a whole lot of things that they wanted to consider. So we've obviously got some respiratory disease going on. Who knows what it is? Is it COVID? Is it flu? Is it RSV? We know she'd been just diagnosed with bronchitis, but maybe we've got pneumonia now. We'll see. And then there's a whole host of other things when you find someone, completely obtunded. It's been a while. Yeah, completely obtunded in bed. So did she overdose on drugs? Did she have congestive heart failure? And this is some sign of a heart failure. Is she in sepsis? Is she dehydrated? Does she just have an electrolyte disturbance? Maybe she was vomiting and had diarrhea or something. We don't know. Considering we don't know, she could have been out for as many as 24 hours. Maybe she's morbidly obese, so maybe she's got some, rhabdomyolysis. Maybe there's some ketoacidosis. I don't know. Let's find out. All right. So those are all of our differentials. So we're going to go through a host of some testing, as you can imagine. So we've got signs of respiratory acidosis. You've got some suspicious-looking radiographs, maybe some infiltrate in the right lower lobe. I don't know if anybody has looked at radiographs. I feel like sometimes they just make it up. Oh, I think I should see some. I don't know. Anyway, and then ran her. I'm assuming probably an NP swab on a respiratory PCR panel, and she was positive for RSV. So that's not great. All right, and then of course we're worried about all kinds of things here: sepsis, electrolyte disturbances. So blood work is done. We have a significant leukocytosis. We have a little bit of hemoconcentration. Maybe that's from dehydration. On blood chemistry, we've got normal potassium. Creatinine is normal. But we do have an elevated creatine kinase, BUN, and glucose, but no sign of diabetic ketoacidosis. So that's good. All right, what else? So we've got PT time is normal. Troponin is normal. We have a little bit of glucose and ketones in the urine, but no sign of infection. What's that about? I don't know. We'll see. And then what's interesting about these medical records, I tried to figure it out. On the first part in the records, they say that her urine drug screen was negative, but then in another part of the records, they say it was positive for cannabinoids. But either way, doesn't matter, right? That's not really going to affect what we're concerned about here. Okay, so the next thing, we did do a lumbar puncture and get some cerebral spinal fluid. Now, that CSF had an elevated cell count of whatever, I don't know the normals, 277, sure. Mostly neutrophils, which is always concerning, and did have elevated protein. So those samples were then sent out, I think, to either a reference lab or another lab in the same network. I don't remember. And that was sent out for a meningoencephalitis panel and then culture. All right, last little bit of testing here. So we had an MRI done. We did see a tiny little abscess in right lateral ventricle, which is never good. But considering, I would imagine, the size, position, whatever, location, neurosurgery did not recommend surgical intervention. Okay, so that's kind of the SO of our SOAP. For assessment, so we've got a bunch of respiratory stuff going on. We've got RSV. They suspect obesity hypoventilation syndrome. So I think I looked that up. We don't actually talk about that in animals, so I'm assuming that's like atelectasis because of position and size, right? We've probably got some sepsis going. We've got meningoencephalitis. We don't know what's causing that meningoencephalitis yet, but we're concerned, obviously. And then we've got some acute on chronic pansinusitis and then an RSV infection. So we've got a lot of problems here, right? A lot to sort through. So then, plan. She was transferred from the ED to the intensive care unit, and then she was continued to be intubated, and at this point she was on ventilation. She was probably on the ventilator to begin with, but that's unclear from the records. And then continue her on a host of antibiotics and some antivirals, and then we were waiting for CSF testing results before we changed any of those medications. Okay, so that's kind of the intro to our case. Now, think maybe in the back of your mind, be thinking about some possible causes, but in the meantime, I'm going to take a minute to 10 minutes to step back and kind of go through a little bit of how we work at DHS and a little bit about our surveillance system and just some basics, so you have a little more context for my work and the work of my colleagues. So as I mentioned, I'm in the Enterics and Waterborne Diseases unit. We just shorten it to Enterics for short because it's just so much easier. Sometimes we will decide to call ourselves in the UDO unit, but it's fun to say, but it kind of sounds ridiculous. So in any case, so I am one of 4 EPIs in that unit. And one thing you guys may know in terms of how government works, there are a lot of different sections, subsections, departments, divisions. So we're in the Enteric and Waterborne Diseases unit within the Communicable Diseases Epidemiology section, within the Bureau of Communicable Diseases, within the Division of Public Health, which is part of the Wisconsin Department of Health Services. It took me many months to remember that. In any case, in our unit, there are 4 of us. We normally have a supervisor. We're in between supervisors at the moment, but what we do is one of us, we take turns on Fridays, one of us every day is responsible for essentially manning. We have a shared inbox. We have a shared voicemail that goes to the inbox. I haven't figured out how to change the voicemail message, so it's the same one I put on in March 2020. It says something about, staying at home to prevent the spread of COVID. It's a historical document at this point, but Man, that was a fun time, wasn't it? Okay, so one of us takes turns every day. We man the inbox, we answer questions, get all kinds of stuff. That is our voicemail number and our email. If you ever want to email any of us, I would say I certainly have my contact information on here and then in some of the materials, but because I occasionally will not be in the office, you're always welcome to contact us as a unit directly or myself. But sometimes I'm not in the office, so there's always someone checking that inbox Monday through Friday through business hours. Some of us are night people and some of us are morning people, so depending on the day, we might start at 9 or we might start at 7. It depends. So as a unit, we cover a lot of kind of our, I think if I recall, the only set of diseases that really beats us in terms of case counts, and I could be wrong, is STI, maybe some of the respiratories. But in any case, we cover a whole host of bacteria and parasites. You'll notice there aren't really any viruses here that are reportable. And one thing to mention, I know Al talked about norovirus. Norovirus as like an individual case is not reportable, but the outbreaks are. And so we get a lot of norovirus outbreaks reported to us, being the most common cause of GI outbreaks generally. So we cover Campylobacter, Salmonella, Shiga toxin-producing E. coli, Listeria, Shigella, all the things. There's some things that are missing here that aren't really, super important, but we do cover some other stuff here as well. So as I mentioned, we cover outbreaks, and like I said, norovirus is the most common cause of our acute gastroenteritis outbreaks, mostly from long-term care. I think depending on the year, it's like 75 to 85% of our outbreaks are in long-term care. And then, of course, anything that you consider foodborne, we cover, anything waterborne, pretty much anything that gives you I learned a new phrase when I moved here 10 years ago, the pee-poos, diarrhea. Yeah, I know. Megan's like, what are you talking about? I don't know. I think it might just be Kim. I'm just going to blame Kim. But yeah, the pee-poos. Now I can't stop saying it, and I don't like it. In any case, I just wanted a lot of you folks, especially at the local health department level, and maybe others will know about our DHS website, but there's a lot of information that we have on that website. Frankly, sometimes I can't even find it, but there's just so much out there. In any case, if you go to dhs.wisconsin.gov, there's a host of little menus at the top there. So if you select diseases and outbreaks, there's way too many choices. But disease reporting is probably what I would suggest going to. Anything that's reportable is going to be at this part of the website. So for example, I believe, let me take a look. This is just the start of disease reporting page. So if you go to category 1 or 2, that's going to cover pretty much everything other than HIV, AIDS, and I think HIV specific, so to speak, diseases. So most of your stuff is in 1 and 2. So 1 is stuff like anthrax, though, so you hopefully don't have to go to that section too much. Pretty much all of our diseases are going to be in category 2. In fact, did I? Yep. All right, never mind. So there are a host of resources that are kind of disease specific. So we've got reporting requirements, reporting methods, and then each reportable disease has its own what we call an EpiNet. It's like a holdover from, I think, the pre-internet days. But they're technically called, I think, case investigation and something protocols. Just call them EpiNets. It's so much easier. There's a lot of information on those EpiNets. So let me see. This is the the E. coli page. If you go to E. coli case reporting, we have all the reportable E. colis. And then if you go to, let's say, Shiga toxin-producing E. coli, there's a lot of stuff you can find, like case definitions. The STEC case definition is really not fun, so if you want to put yourself to sleep, go ahead and read it many times. In addition to that, we have, this is probably some of the more important info is public health interventions and prevention measures. So I have this little note here that says that LTHDs are responsible for allowing people to return to work when they're in high-risk settings. That's just a little bit of a reminder to mention. that providers, for example, don't have the power to tell someone that's like a food handler to go back to work. That's usually the local health department's job. In any case, this little kind of circled portion kind of tells you some of the like exclusion criteria and return to work criteria, stuff like that. You can find that for just about everything on our website. Okay. I won't go into this too much, but one thing that's, especially in my section, I don't know about the rest of the division, we don't really, us at DHS, we don't really have any kind of regulatory power. So in the state of Wisconsin, we are what you would call a decentralized or a home rule state. So our local and tribal health departments have kind of all the power to enforce the public health statutes and the rules. And in any case, there are a lot of different LTHDs in the state, and last count was 96. We've had some mergers and such. So those are divided into public health regions, and then of course there's us at DPH, DHS, whichever you prefer to call us on the given day. Just call us the state, right? So as I mentioned, yeah, we're a home rule state, decentralized. LTHDs have the power. I really wanted, this is gonna age me a bit, I really wanted to see if I could find like a photograph of like, was it He-Man or She-Ra? And like, LTHDs have the power, and I'm like, yeah, you're either too old or too young to get that reference. I apologize. I hope that it's that you're too old, but I doubt it. Okay, so we are just responsible for guidance, essentially kind of being the experts. I know we rely on CDC a lot for that too. And then we're there to support with surge capacity. We certainly did a lot of that during the worst parts of COVID. And then the big one is we oversee statewide surveillance. Okay, and this is just fun. We might be one of the only units that can actually help local and tribal health departments with conducting follow-up, which is really nice. Unfortunately, I will mention, we just lost a bunch of money, so we were able to do like 50 to 60 hours for all together for help with our interview team, but we got cut to like 32 or something. But in any case, we can still help. So the job, or I should say the goal of our interviewing team, we call them the Surveillance and Outbreak Support Team, SOS team, because that's fun. They're able to help local health departments and ourselves with improving, essentially the goal is to improve our surveillance, and that's by doing things quickly and completely. I had forgotten to mention this in some of our other road shows last week, but one of the most important things for us for our diseases is to get reports very quickly. Now, I know statutes say, like for example, our Category 2s, I think, have to be reported to the local health officer within 72 hours. Thanks to electronic lab reporting, that's usually pretty instant. There are some things like hemolytic uremic syndrome is a syndrome. It's not like a diagnosis via like one lab test. Any of those things, whether they're electronic or they have to be reported manually, the faster we get them, the better it is. So think about, all right, let's say today is what, the 17th. Let's say you get sick with, I don't know, diarrhea and vomiting today. I sure hope not. Depending on what made you ill, the incubation period could have started 2 weeks ago, right? Let's say it did start. Let's say you got exposed to the pathogen 2 weeks ago. That means the minute you get diagnosed, so let's say you go to the doctor today, you get diagnosed tomorrow, you're already 2 weeks behind in terms of time, right? And we try to get as much information as possible from as many people as possible so that if and or when they end up being part of an outbreak or a cluster later on, we already have the information that we need to say, oh, it looks like these 5 people did this one thing. Let's go take a look and see if there's something there. So that's one of the mainstays of Enterics. Follow-up is fast, fast, fast. In any case. So yeah, so they help us with what we would call our kind of routine reportables, case interviews, as well as helping during outbreaks and just basic data support. Okay. So that's enough of the slightly boring part. So at this point, we've talked a little bit about our case. I'm giving you a little background on kind of what we do. So how do we actually get from testing at a clinical lab to boots on the ground, like actually doing something about it? Okay, I'm sure most of you, if not all of you, know about our surveillance system. It's called WEDS. It's web-based. And again, like for the most part, most things come in automatically via electronic lab reporting, which is so nice. We do also get web reports. I think pretty much all, it's just IPs that write them, but I've never actually checked. So if folks, you can let me know if I'm wrong. But we can get lab reports electronically or automatically, and then we get web reports sent to us as well. And anytime, and you can set this up with the WEDS folks, anytime one of kind of our big 3 or 4 diseases gets imported in WEDS, I get an email, and so do most of my colleagues. So same for local and tribal health departments. Now, this isn't really super exciting, but that's, oh, look, that's the notice I get. So this isn't like the same, this is not related to this case that we're talking about here, but essentially it says the disease. There's usually just a little bit about the lab results. I can often tell if something is like a wrong, like incorrect right by looking at that, because I've looked at I don't know how many thousands of these over the last 6 years. So we get a notice that there's a new, let's say, Listeria case, and then I can go and take a look. This is not a real person, obviously. I can go ahead and take a look. Oh, this is Jennifer Doe. She lives in any town, and let's take a look at what's going on. I can go to like the filing cabinet and look at lab reports. They look like this. I will say they are, when you're new to looking at these, they kind of look like a whole bunch of nothing because of the reference ranges. Sometimes look a little confusing because your normal is not detected, but then we have detected. So that's a positive on a PCR panel for Listeria. Hint. And then when the clinical lab, I think for the most part, anytime they do CSF and they run it on a panel, they're also doing a culture probably at the same time. And this is what a culture positive looks like. You'd be surprised, sometimes it's really unclear what the actual test is, and it's all just a bunch of like mumbo jumbo lab / informatics stuff, but this is what a positive would look like. All right, so I get a notice of a new Listeria case, right? What I try to do with Listeria, because it isn't super common, very concerning, of course, because every Listeria case is really can be very, very serious. And in fact, most of the time they are when we get a report. But I try to contact the local or tribal health department as soon as possible and send them the specific CDC interview form, which is, we'll go into that. It's a kind of a mess. And then I just give a little bit of information, and I ask them to contact the clinical lab and say, hey, can you make sure you send this to the state lab? And then I'll offer help if they need it. I try not to because it's a pretty ugly interview, but we certainly offer help. All right. Listeria is really hard to investigate. If you think about it, most of the time when we get a report of Listeria, well, first let me back up. There isn't really a way, as far as I know, certainly not commercially available or even clinically relevant, to test stool for Listeria, because frankly, it's not really important, because we really only care about Listeria when it's invasive. So almost all of the time, if I get a Listeria case report or a Listeria lab, it's going to be in CSF, blood, on occasion something really wacky, but it's always generally something that's supposed to be sterile, right? Urine is not, we don't get urine. In any case, we get that, so people are usually really, really sick, right? Because we've probably got sepsis or meningitis or meningoencephalitis or a whole host of other things. A lot of times they're older adults that have a bunch of other comorbidities. It's very common to have Listeria cases that have dementia and can't really report anything about themselves, whether they're at home or in a nursing home. God forbid they're in a nursing home. So when we got initial lab results for Jennifer, it was one day after she had presented to the ED. So she's still, she's completely out. She's on a ventilator. She's not conscious. She can't answer questions. When the local health department, checked up on the case a few days later, she was still in what the brother called a medically induced coma, so she was still not able to speak. She lived alone, and she had a sister and a brother, and they were like, I don't know what she ate. I couldn't tell you, And they certainly didn't know what she'd done in Florida. So within a few days of getting those initial reports from the clinical lab, the investigation kind of stopped. And that happens all the time, unfortunately, especially with listeria. All right, so in addition, so I said it was hard to investigate for those reasons. In addition, the form is not my favorite. If you think about what most of our listeria cases are like, it makes sense the way it's set up, but just to give you an idea, and hopefully you can see a little bit of this. Yes, this is just for the lab information, and this is a case definition. Don't read it, it hurts. Then we have the patient interview, which, could they make it in smaller font? It's like it's designed for you to skip stuff, I swear. The incubation period that we ask about in a listeria interview is for 30 days. Which, again, think about this. I think the typical incubation for listeria is 2 weeks. You're probably really, really sick when you get diagnosed. If you tried to remember what you ate yesterday, would you remember? No, I can't remember. I just tried. I don't remember. But we ask a lot of questions. These are all really important questions. And sometimes we get what we need, but a lot of times we don't. So we ask about every store you bought stuff from that you ate in that month. We ask about for shopper card records. If you ever, God forbid, you get an enteric disease and someone calls you and asks for a shopper card record, that's sometimes the only way we can solve outbreaks. So like, for example, a few months ago, there was an outbreak of salmonella, I believe. It was my outbreak, and I still can't remember if it was salmonella or STEC, but it doesn't matter. There was an outbreak linked to basil sold at Trader Joe's. We were able to get records from Trader Joe's to prove, you got this basil on this date from this store. Like, that's how we solved the outbreak. So all of these details are super important. So this is the first page of the interview. And then we ask about cheese, all the cheeses, so many cheeses. Other dairy, I don't know what other dairy is other than yogurt, I guess. All the seafoods, all the fruits, deli meats, other meat, vegetables and other produce, more other produce, deli salads, and then all the other things. So, yeah. I said this a bunch of times last week, but if I have an excuse to put a cat on a slide, I will do it. Okay. So the investigation had stalled, and then, at some point, probably only a few days after we got that clinical lab report, or the clinical lab culture report, the lab had forwarded that isolate to the state lab, and the state lab confirmed the initial culture results. And then at this point, somewhere in the background, the state lab does their magic. I'm not a lab person. Thank goodness for you guys that know what you're doing, because no, I'm not. So they do their magic. Yeah. All right. And then about 2 weeks after that, I got an email. Well, I should say, so the whole genome sequencing data is uploaded to PulseNet. Al talked about PulseNet. That's where all the things go. Usually, I think there are others, but we rely on that for salmonella, Shiga toxin-producing E. coli, and listeria. So all the things go in there from all the states, probably territories too, and Canada as well. I don't actually know if other countries go in as well. But soon after that, I got an email from CDC reporting that we had a Wisconsin case of listeria that matched cases from an old outbreak in Florida. Which is weird. That's just weird. That doesn't really happen all that often. Okay, so if we step back, so Jennifer presented in early 2024. If I recall, it was actually January, February. A year previously, and I believe it was late winter, the Florida Department of Health had ID'd 4 listeria cases that all reported eating at the same restaurant in Swampsville, Florida. Now, Swampsville, Florida is not a real town, and I cannot believe that it isn't. Bob's Big Boy Buffet. So Bob's Big Boy is a real place, but it's only in my hometown of origin, Los Angeles, and there are only four places left. So that's fake. Anyway, Florida Department of Health identified 4 cases eating at Bob's Big Boy in Swampsville before they were ill. Florida took multiple swabs of multiple places in this restaurant. I believe, I can't even remember, there was just a bunch of swabs, probably some in the walk-in cooler, probably some from the buffet. And they also took a sample of food from the buffet, and all of the cases in the Florida outbreak matched listeria isolated from a sample of honeydew. Not supposed to have listeria on honeydew. I'm not sure if you guys knew that. It's not a part of honeydew. So then Florida worked closely with the owners of the restaurant to do remediation, what we call remediation. So a lot of you guys know, you're microbiologists and what have you. Listeria is really difficult. It likes to hide. It doesn't, it survives really nicely in refrigeration. In any case, they did a lot of really in-depth work with the restaurant to try and work on places that the listeria could have been hiding. So they had cracked flooring in the dining room. They're like, you want to get rid of that so you have something that's a little smoother that you can mop it every day. I know that there was like a wooden shelf in their walk-in fridge. Well, you can't really sterilize a wooden shelf. So let's change that to stainless steel. So there's stuff like that. They worked really hard with Bob's Big Boy. And yeah. So I felt really bad for Florida. So they had thought they had corrected all of the problems at our buffet here in Florida. It's funny, it felt like it was closer in time to our match their outbreak, but I think it was actually probably 6 months later. But they had considered it a huge success story for their department. They had also presented it as a success story at, so there's a big EPI conference every year in the summer. It's like a week long. It's like the worst time for enteric EPIs because you guys know Salmonella, Listeria, S-Tech, all the bacteria decide to go crazy in the summer. So they say, hey, why don't you take off a week from work and go somewhere else? But anyway, Council of State and Territorial Epidemiologists has a huge conference every year. Florida had presented about this outbreak as a success story to a bunch of EPIs throughout the country. And then CDC's like, hey, just kidding. So we got this random Wisconsin person that matches from a year later. Sorry, So Jennifer's isolate, once it had been sequenced and uploaded to PulseNet, CDC essentially told us that her isolate matched every single one of the 2023 isolates from Florida, and the environmental swabs. They all matched, like within 0 alleles, so they matched. Okay, so we had not actually been able to interview Jennifer or her siblings because, there was a whole host of other things the local health department had to do. They had asked the siblings, hey, if Jennifer gets better, because frankly, I didn't think she would survive based on the records I had. It was pretty nasty. If when she's discharged, I'm sure they didn't say if she's discharged, that would have been a little cruel, but when she's discharged, have her call us. Now, it didn't happen. I can't imagine why. It's not like she wasn't busy recovering. But, at this point, several weeks after, she got back from Florida, she survived, and she was home, and she was recovering, which was really nice. In any case, so we had not done the full 8 to 20,000 page interview with Jennifer, but because we had these matches and we had such a really, this is like we know what made her sick. That's about as close as you're going to get to certainty in our line of work. So what we asked the local health department to do was to call her and to ask her some, what we would call, it's called iterative interviewing, right? So we called her, confirmed that she'd traveled to Florida. She was there for 10 days. She had returned 2 weeks before she was hospitalized, as we mentioned at the beginning. When they first talked to her, she was pretty sure she'd eaten at Bob's Big Boy. She had to check, though. Thankfully, she had gone with a traveling partner, and that person had kept the receipt from, I'm thinking, like I said, maybe 6 to 8 weeks later, so they still had the receipt. So they confirmed the date that they'd eaten at Bob's. They confirmed where it was. So it was Bob's Big Boy Buffet. Again, real place, not a real place though, in a fake town that really should exist in Florida. And she had eaten there 2 days before she left to return to Wisconsin. So, with that information, Florida probably sighed really deeply and said, oh, okay. And then they returned to Bob's Big Boy, did further investigation. They didn't actually keep me updated, so I had to look in the database to put this together. But I looked in the database, and they took maybe 4 to 6 more swabs of the restaurant. And and a seafood deli salad, and they all matched the 2023 outbreak, the 2023 swabs, and then the 2024 case. And it turns out they hadn't removed that wooden shelf, which Florida was like, oh, come on, So that's the update I have for that. I would actually thought about emailing them and being like, hey, how did it go? But I frankly don't have the time as much as I want to know. So getting to the point, or I should say the overarching point. Okay, so I can't overstate this, but that would have never happened if that isolate hadn't been sent to the state lab, right? There's just, in no way would we have had the slightest idea. If you know a person has listeria, that doesn't tell you anything. We get, I think 20 to 30 cases a year. You're not going to be able to narrow it down, especially with that interview form. It's just not going to happen. So that is the foundation of basically all food safety, not only in the state, but across the United States, because certainly people travel, right? And that's how we link things to other states. This happens probably a good handful to 10 times, I don't know. It happens a lot every year. Well, we've got Wisconsin cases that match a Colorado outbreak, or, I feel like it's usually Florida, poor Florida. But yeah, without these specimens, there's no way that the state lab would be able, only the state lab can do the type of subtyping that we would need to do this kind of work. So, like I said, we could pinpoint it to a very specific location. If you can pinpoint a person's illness to a room, that's crazy to me. So we could pinpoint what caused her illness. Florida could address it. And, there might have been other cases that we'll never know about between 2023, 2024. I don't know, right? But we have no idea what could have happened after January, February. I frankly was surprised Jennifer survived, as I mentioned, but there might have been more cases that might have died, because I think I have to find this and stop. I have to find the number, but to my recollection, case fatality rate for listeria is 20%, give or take. I think that's probably a good estimate. I just need to find the paper. But that's really high for enterics. And so 20%, that's what, 1 in 6, 1 in 5? It is like playing Russian roulette, the numbers almost work out. So essentially, that clinical lab probably saved lives that they'll never know about. We'll never know who was saved, right? Because when public health is working, it's silent. It's not sexy, but it is silent, and it does save lives. All right, just to really drive this point home. And these are just a few outbreaks over the last few years. 2020 was real fun. It wasn't. So, for example, we had a salmonella outbreak in 2020 linked to red onions that were actually grown and distributed out of California. That was a huge outbreak. It was 1,000-something cases that we knew about. Or that same year, we had salmonella linked to peaches, and I believe those were those I can't remember. I think they were also California peaches, which is why it's kind of odd that it was only in the upper Midwest in New York. Then we had another onions outbreak in 2021, which was real fun because I had to work on that one too. And then, of course, we had, we'll occasionally have stuff linked to packaged salads. But then, we were talking about this boar's head nasty, nasty outbreak. I'm frankly surprised we still only have 1 case in Wisconsin. But every single one of those outbreaks is a clinical lab in Wisconsin, several in Wisconsin, and all across the country, sending those isolates and or specimens to their respective state labs. Those state labs doing all of their work, uploading it to PulseNet, somebody looking and seeing what matches and what doesn't, and then all of us EPIs putting our heads together and saying, oh, it looks like it's this. We cannot solve foodborne outbreaks without these isolates. It's unlikely, I'll just say. All right, so that, oh, look at that, only 1 minute over. So that is all I have, and of course, I am open for questions.
Any questions, anyone? I'm happy to run over with the microphone.
Anything at all.
Comments? Surprised to hear that we link a case in Wisconsin down to Florida and that this happens? No?
Yeah.
Okay.
Yeah, a lot of people go to Florida. A lot of people go
All
to
right.
Mexico, too.
Okay, then let's go ahead. Now we have our little 15-minute break. So go ahead and warm up your coffee, have some refreshments, and thank you to Dr. Roberts.